to you, our speaker today. Angie McKinney Jones is the director of the Tennessee Office of Prevention Services, which is located in the Department of Mental Health, the Tennessee Department of Mental Health and Substance Abuse Services, which is one of the departments in the, I guess, in the governor's cabinet, right? As the commissioner for mental health and substance abuse services. Doug Varney is her boss. Angie McKinney Jones, Ms. McKinney Jones, works to ensure that Tennessee reduces the use and abuse of alcohol and drugs through a strategic plan that encompasses strategies focused on increasing protective factors and decreasing risk factors at the individual, community, and state level. She's the principal investigator of the Screening, Brief Intervention, and Referral to Treatment Grant, which is from Santa. Is that right? Yeah. And also the Partnership for Success Grant, and also the PI, the prevention portion of the Substance Abuse Prevention and Treatment Block Grant, which has recently got a new award, and I'm sure you'll tell us about it. Okay. She's a Master of Science and Social Work graduate from the University of Tennessee at Knoxville, and a Bachelor of Arts graduate from the University of North Carolina at Chapel Hill. I had the pleasure of working with Angie to imagine how we might get more engaged in primary prevention activities in the state. And I'm delighted that she's here to present, I guess what is now the 5th or 6th training rounds in prescription drug abuse issues. Yeah, grant rounds. It's mislabeled as 2nd on the flyer, but I think we've been doing this for about a year now. So delighted to have you here, and thank you for coming.
Thank you. Turn myself on. Can you hear me? Yes? Okay. Well, thank you for having me. It's good to be here. I consider Eastern Tennessee home. I'm from Western North Carolina, and so it's always good to be here. I drove last night to Waynesville. Anybody know Waynesville, North Carolina? Okay. So I drove to Waynesville, dropped off my son, and drove over this morning. So it's really, really nice to be here. And yes, so thank you for having me. And I'm really excited to talk to you about prevention in Tennessee. I'm going to do more than just prescription drugs, so I hope you'll allow me that. It's a little bit more broad what I'm going to talk about today. But I did bring some Prescription for Success, and we'll talk a little bit about the Prescription for Success plan that the department's been working on and that the governor endorsed and that we're really proud of. So, all right. So, the state of prevention, we've been really proud in our state that we think that we are developing a prevention system, and we'll just talk more about that. I don't have any financial arrangements to disclose to you, so we can skip on to the next slide. I thought I would start with some prevalence statistics, since you guys are good public health folks, and talk about the problem that exists in our country and in our state. We know that it's estimated that 24.6 million individuals aged 12 or older were current illicit drug users in 2013, including 2.2 million adolescents aged 12 to 17. And I put state of Texas on there. Anybody know why? That's about the population of Texas. So just really beginning to think about how, you know, if every person in the state of Texas were using substances, that's what our prevalence looks like in the United States. And the next one is about binge drinking, which we know is a huge problem. That's been an effort that we've been working on for quite some time in Tennessee through our current Partnership for Success grant. But we know that in 2013, 60.1 million individuals were past month binge drinkers, including 1.6 million adolescents. And again, this adolescent number always worries me as you think about people getting that age group. It's a very risky time in people's lives. But the sheep are there because that's actually the number of sheep in New Zealand, about 60 million. It's actually about 20 sheep for every New Zealander, as I understand it, you know. And so, again, I don't know that you know a lot about sheep in New Zealand, but as I understand it, there are a lot. And there we have it, about 60 million. The cost of substance misuse in the United States, we know that alcohol costs about $191.6 billion every year to our society. Cigarettes, tobacco costs about $167.8 billion, and illicit drugs cost $151.4 billion, and that illicit drugs includes prescription drug misuse. to total $510 billion annually. As I was looking at this morning, I realized I didn't do a good job citing, so I can cite for you guys later if you're interested in my sources, and I'm sorry I didn't include it on my slides. But these costs come from a variety of different things. They are obviously cost to the criminal justice system, cost to our healthcare system, cost for productivity, lost productivity. So they're in a lot of different arenas. In Tennessee, we know that 7.95% of the Tennessee adults ages 18 or over abused or were dependent on alcohol or illicit drugs in the past year. And then an estimated 17.3% of Tennessee's young adults ages 18 to 25 abused or were dependent on alcohol or illicit drugs in the past year, compared to 6.4% of adults. Again, this slide really points to me to the huge concern of that 18 to 25-year-old age group. When you're sending your kids off to college, when they're kind of getting off on their own for the first time, it's a very risky time period. I have a 4-year-old, and so I say that when he's 18, we're currently building the underground shelter. So he's just not going to leave. It's such a scary time. So impact of substance misuse and abuse. We obviously, this is just, it's manifold. Many different things occur because of substance misuse and abuse in our country. We know that there are lots of physical health problems that are a direct result of it. Not to mention, accidents and things like that occur. This is a slide actually taken from Prescription for Success, and so this speaks a little bit more to prescription drugs specifically. The number of emergency department visits for prescription drug poisoning has increased by approximately 40% from 2005 to 2010. And that's a pretty staggering statistic that we know. And that's, just looking at it over time, we can see that this is a big increase. We know that there's the new bill, naloxone, that should begin to help with some of this. But, this is obviously a major concern, and we're really quite high. And then the Healthcare Cost and Utilization Project shows the total charges for hospital charges for prescription opioid poisonings has risen exponentially over the past 10 years. And in 2001, the cost was $4 million approximately, and it's increased by 600% to $29 million. So again, these are pretty darn staggering statistics, and we know that this is certainly a problem in our state, and you guys have seen the data just like I have, where it really pinpoints it right here in East Tennessee. Some overdose deaths and numbers from 1999 to 2010, the number of people dying from drug-related overdose increased at a greater rate in Tennessee than in the United States. There has been an increase nationwide, but Tennessee has been growing at a much higher rate than the nation. Criminal justice system involvement, this one's always concerning. Drug-related crime against property, people, and society has increased by 33% from 2005 to 2010. And then we have the cost also for apprehending, prosecuting, and incarcerating people, which is just costing our state millions and millions of dollars. Probably one of the most heart-wrenching statistics is around children in state custody. We know that prescription drug use and substance use is one of the primary reasons. About 50% of kids that go into state custody go in as a result of their parents' alcohol, drug use, and so this is staggering. And you guys are all pretty darn aware of the NAS problem, or neonatal abstinence syndrome problem that's occurring here. I think that's my next slide. This is the slide that shows, and I'm sorry, I did not do the most up-to-date one, but what we have here is the average cost to stabilize a newborn with neonatal abstinence syndrome is $62,000, while the cost of birthing newborns who are not suffering withdrawals is only $70,000. So they're much more expensive to hospitalized, to care for when they're born. And the 660 is there because that was the number, that 41-week number last year. And again, this number continues. We continue to have this reporting done, and we know neonatal abstinence syndrome is a huge problem in our state. One one of the interesting things here is that the statistic about among all TennCare infants born in 2012, 1.6% were placed in DCS custody within 1 year of birth, but infants born with neonatal abstinence syndrome were 14.8 times more likely to be placed in DCS custody. So very staggering statistic. All right, so I told you all the bad, that's the problem, and so what are we doing to prevent it? Hopefully a lot. And so this is our definition that we use for prevention: proactive activities that empower individuals, families, communities, and systems to meet the challenges of life events and transitions. This focuses on multi-levels, individuals, families, and communities, and then really giving people the tools that they need before they meet those transitions, those challenges. And this is my favorite prevention analogy. So I finally did a lot of work with Photoshop and made you some pictures. But the usual approach, and I think this is really true. Has anybody heard this poem? It's a pretty wordy poem. It's about it. The gist is here. An ambulance or a fence. And our usual approach, as I termed it, is that we put that ambulance at the bottom of the mountain, and we wait for everybody to fall off the mountain, and then we put them in the ambulance and we rush them to the hospital. And that's pretty darn costly, and it's pretty intensive, and it's pretty life-changing. And so what we as preventionists kind of talk about doing is building fences. So if we can build a fence around the top of that mountain, how can we keep someone from falling down and undergoing those really serious consequences? They never have that break. They never have, something really catastrophic happen to them. They get to stay at the top. They get to be shielded by that nice fence, and it's a better approach. And more cost saving if we want to look at it in dollars and cents terms. Maybe more on the front end. Building that fence might take a little bit more money initially, but later on it will be cost effective. So Tennessee Prevention Services, again, we create and reinforce conditions that we know effectively promote healthy behaviors and lifestyles. And our prevention services, we are focusing on alcohol, tobacco, and drugs, illicit drugs, as well as prescription drugs, which has obviously been a focus of late. We are working to reduce their negative consequences. We talk a lot about consequence data in our work. Sometimes that's just because we can't get good other data. It's really hard to get data that says that, the percentage of people that drink, even NISTA data, which is where a lot of my stats come from, or the National Survey on Drug Use and Health. It's limiting. There's not that many Tennesseans that are part of the NISTA survey. So, we end up focusing a lot of our efforts on consequences, and we certainly want to reduce things like people doing DUIs or dying in accidents, things like that. And we want to minimize the future needs for addictions treatment. Okay, so I thought I'd talk for a second about our theoretical perspective. Obviously, we have a lot of our theory comes from public health model. I think we're the only part of my world, so when I say my world, I mean the Department of Mental Health, that really thinks from a public health perspective. And sometimes I feel a little bit misplaced, like I should be over in the Department of Health, because we look at things a little differently as preventionists and as public health focused than the rest of the world does. We're kind of focused on treating one person at a time. It's a little different. But we've come to sort of think of the frog or fish in the pond analogy, thinking about, would we want to treat if a couple fish come up sick, are we going to go and look at every fish individually, or are we going to look at that pond and look at the conditions in that pond to see what's going on? So that's what we're trying to do with prevention in our work on a systems level. And then promotion and prevention are key. I'm going to talk more about the Institute of Medicine's IOM continuum, but that's kind of the beginning levels of that. And then the risk and protective factor model. And I'm not sure how many of you, this comes from the physical health world. There was some research done by two guys named Hawkins and Catalano many years ago. And their whole idea, they took it from physical health world. They took it very much from the Fahrenheit heart studies. And so the idea was that, what are the things that are making people more likely to use substances? What are those risk factors, things that make you more likely? And then the protective factors, those things that protect against your use. And so we've been able to isolate that for not only substance abuse, but also for behavioral health in general. And so we know that there are some risk factors that make people more likely to abuse substances. And there are some at the individual level and then some at the community level. And we'll talk more about some of those as we go on. And then multiple contexts, we've already talked about that, individual, family, community. And then developmental perspective. We have found recently, everyone has looked a lot at the 0 to 3 work that's been done with the Adverse Childhood Experiences Survey, and we know that, there's something to be said for what happens in early childhood. There's something to be said for what happens in late adulthood. As we go through transitions in our life, those impact us. And so as preventionists, we want to look at each of those life changes and life theories. And then planning process. This is where a lot of our grants have come from. We keep talking about our SPIF-SIG and things like that. SPIF-SIG stands for Strategic Prevention Framework, which was a beautiful planning model that somebody came up with and got to stamp their name on. And it's become the model that we use in prevention. But it's a strategic planning model that we take pretty seriously. We look at, we assess. Do community assessments, try to decide what is the problem. Then we do a capacity assessment, try to figure out what capacity exists in the community. We plan, we implement, and then we evaluate and try to sustain it. So nothing different, just another pretty name for this. All right, so the Continuum of Care Protractor. This came out of the Institute of Medicine's work, and it's guided a lot of our work. And so as you think of it, over on this side, you have the things that are more for the whole population, and as you get over, it's less individuals. Now you get, and you also get more intensity kind of as you go along the continuum. Now that kind of backs up a little bit because over here, they're using the term maintenance. We often call it recovery. And you can also think of this, we've often thought of this in our world as prevention of. So over here, you're doing prevention of use, prevention of a disorder. Here, you're doing more like prevention of relapse, things like that. So how do we think of it in those ways? I'm going to focus some time and energy talking about the prevention portion of this, which is right over there. It's the universal, selective, and indicated portions. So, universal prevention as we see it, directed at the entire population. We're not thinking about risk. Just everyone, for a long, long time, we did it curriculum. A lot of our work was curriculum-based, so every single third grader, we all had DARE, right? Every single fifth grader got DARE, and that was a universal prevention strategy. Nobody was recruited based on risk. But now we've kind of switched our philosophy a bit in Tennessee to work more about universal prevention in terms of communities and really thinking about how we change communities, how we do environmental work. So I'm going to talk some about our coalition level work and some of our other, broad work. And so one of the things I wanted to make sure you had seen, if you haven't, we haven't done a good job. But that's our prescription drug media campaign. We started airing this last year. And again, this was aimed at the whole population. It's been airing here in East Tennessee for a while. And let's see if it works. Fingers crossed. I'm not always perfect with technology. It's thinking. Okay, I think it might actually work. Or I said it too soon. It takes 15 seconds once it comes on.
Oh, go back to the other.
Go back?
No, to the other tab. See, there's like, it opened another tab.
Okay. Could be.
There we go.
Yep, Jennifer, you're so good. All right, so here it is.
In Tennessee, enough prescriptions have been written to give everyone aged 12 and over 51 hydrocodone pills, 21 oxycodone, 22 Xanax, and a host of other drugs. No one ever plans to become a drug addict. But prescription addiction is a statewide affliction.
You got the picture point.
Take home as directed.
So have you seen it? Have you seen it? No. All right. this is something we did. That is all controlled substance monitoring database data that we use for that that campaign. And we also had some supporting materials that went along with the TV ad. We had some things in pharmacies if they were willing to have them, some ceiling hangers and floor stickers. We've obviously had this brochure and just trying to get out the real problem. But I wanted to talk a little bit about our community anti-drug coalitions because they have done such amazing work in our state. I have some, Washington County is represented here today, or Insight. Do you call yourself Insight Alliance? Mm-hmm. Insight Alliance is represented here today. And our coalitions have done such amazing work at the community level. So I wanted to talk to you because I feel like coalition work, it's really easy when I talk about a program to tell you what a program is doing. But a coalition is not quite as tangible. It's not quite as easy to say this is what they do. So I'm going to try to show you some community examples of what's been going on in our state around prescription drugs. But their work is trying to change the conditions. They're trying to change policies, practices, procedures in their communities to make them less likely to use substances. So I'm going to show you, these are our coalitions across the state. If it's in blue, it's where we have a county coalition that we fund. That doesn't mean that there aren't other coalitions in the state. As a matter of fact, we queried the other day, and there are about 10 coalitions, even Carter County, I hear, that are trying to get their start, which we're super excited about. And so this is a map of, showing where we have coalitions currently. And some of our recent work, we've done a lot of work, as many others have. This has not been on our own, but with prescription drug collection boxes. And so when we first started keeping count, and I'm not sure, do you know what I'm talking about when I talk about permanent prescription drug collection boxes? Yes, okay. When we first started keeping these numbers, there were 36 in our state. We're up to 104 now across our state. And the map is showing you the number of boxes in counties. We've done a great work kind of increasing the number. We clearly have more work to do. If it's white, we don't have one at all. But there's also places where we just simply don't have enough. Shelby County has one. It's easy to see that that's not enough for that population. Davidson County has done some great work. They have one at every single police precinct. So I think they're at 7. Franklin County has one at every police precinct. So it differs by the county, but and it must have law enforcement cooperation in order to get it in those law enforcement offices, which is what has to happen for now. I think you guys are aware that the FDA just published new regs that will allow them to actually be in pharmacies, so pharmacies can take back drugs, which should really increase the number of drugs that are being taken back. My interest is going to be on how many pharmacies are willing to take them back, right? Because it endangers them. All right, so this is another great coalition effort that's been going on in Coffee County, and I believe Johnson County as well has been involved in this. Yeah, and so this is called Count It, Lock It, Drop It, and this was their sort of prescription drug initiative, and they have received some national recognition because of it. So I'm going to show you a little short video, and I also like this video because what it does is it shows what a coalition does in their community. It shows their partners and how they work together. Let's see.
What I think really helped us with the outcomes that we have achieved is that we have this strong foundation of peoples and partners that are willing to work with us. The staff is there to assist, but it is so community driven, and we've been able to really do this work that the community owns and sees as their own project.
Our permanent prescription drug take-back program really is sustainable. Besides getting data back from our law enforcement, we don't have anything to do with that anymore. They set the policies, they set the procedures, and they're full off and running with that in our 3 law enforcement departments.
All the coalition basically did was got us started in that, and our police department took that over from there. And that's how it's got to be in a coalition. They help us get it started. And then it's up to us to keep it running and to make it work.
With prescription drug safety, our pharmacists and our doctors have taken that on as their own, and they're doing that at each point of contact. One of our pharmacists goes to different groups and talks about it without us asking him to do that. So he's a key sustainability piece to the education.
I think many times we as healthcare providers may not even know that the problem exists until it's brought to our attention. For example, I had given a presentation to a local dental group. We have a controlled substance monitoring database in Tennessee that providers can look up to see where patients have gotten these controlled medicines filled. The dentists weren't as aware of this thing as a tool to help to curb this. In educating these dentists about this, I told them about the database, how to look the patients up in this database to find these potential abusers, and then just to let them know that maybe the quantities you write for could be changed, and even that simple act could decrease some of the diversion right there.
One of the reasons that the coalition hired me was to create the lead group, which is our high school arm of the coalition. And we meet with them at least once a month. When the coalition does something, a drug take back or something like that, we invite them to come along. When we do initiatives in schools and campaigns, we invite them to design the material. Then we run it through does it fit? Does it work with what we're trying to get done? And then so they drive those ideas. They drive most of those things.
One of the things that I do working with the school system is as a connector between the coalition and the schools, I've got access to data. Working with central office, I've got access to personnel that can approve some things fairly quickly. So that's been a good position for me to be in helping the coalition over the years.
I think that the coalition and the staff have been successful because they found not just people from each sector, they found the right person from that sector. They've allowed an environment of discussion that permits people to voice opinions and find a way to move forward with everybody's support.
And it really took getting to know what we call dating our individual partners and spending time with them. The odds are staff aren't always going to be there, but if you have these partners at the table, they're going to sustain these projects. And when they understand it and they own it, then you have a lifelong organization.
Yeah, so I love that example because it really does show what coalitions are doing in their community. And again, what they're doing, if you count it, lock it, and drop it, it's threefold, it's got many tiers, and it's something we're going to be rolling out with our new grant that I'll talk about for a second right now. The new grant is a new 5-year SAMHSA grant, and it will specifically focus on the prescription drug problem in the 12 to 25-year-old age group. And we have concentrated it mostly in East Tennessee. There are 3 counties right here in Region 1, as we call it, Mental Health Region 1, that are a part of the project: Johnson, Sullivan, and Washington. And so we are really excited, and we're also excited about how they can work together to get the rest of the region involved in these efforts. This grant is $1.4 million a year for 5 years. And that's in our world, that's about a $900,000 drop from where we have been with our previous Partnership for Success grant. So we were only able to fund about half of the number of coalitions with this effort that we have with previous Partnership for Success grants. So that's been hard, but we're really hopeful we'll see some state level outcomes because they're concentrated in this area, which we know is where the problem is. Okay, and then I think this is my last video, but this one is awesome because it talks about enforcement, which is another thing that many of our coalitions are involved in. And it's also kind of and this just happened a couple weeks ago, actually. So it's a great, very recent example of some great work.
Selling alcohol to minors is an increasing problem here in Nashville, and Metro Police are working to put a stop to it. Undercover agents raided several businesses today, and this News Channel 5's Jennifer Reyes shows us it wasn't the first time many of those businesses have been in trouble for selling to minors.
Does the exact same thing. Here's our young person right here.
Video provided to us by the Nashville Prevention Partnership.
What I want to do is show you some of the footage that we've got.
Shows an underage person walking up to a counter to buy alcohol.
And there's the transaction.
Investigators say selling alcohol to minors happens frequently here at the West Trinity Market and Trinity Liquors.
6 times at the liquor store, 5 times at the convenience store over the process of a couple of days.
It's 2 separate businesses and 2 different clerks not asking minors to show their ID.
This happens to be on one street, on Trinity Lane.
Metro Police showed up one last time Thursday afternoon. This time, it wasn't to ask questions.
Police are standing there talking to the guys.
It was to make an arrest.
I guess they're going to lock them up or something. I don't know what they're going to do, but they're going all back through their inventory and stuff.
And hopefully put an end to this situation that puts many people in danger, not just the teenagers buying alcohol.
You should always ID, follow the law.
For the last 5 years, the Nashville Prevention Partnership, a nonprofit group, has been working with Metro Police to prevent the continued sale of liquor to underage people.
It may not be your child. It may be a friend of your child.
Last year, undercover minors went to 173 locations in Davidson County to see if businesses would sell to them. 56 clerks did.
And so you still have to be cognizant of the fact of what's going on with your children, what's going on with their friends.
The situation doesn't sit well with loyal patrons.
Every day. I buy cigarettes and beer every day, and I have to show my ID.
Who say clerks need to follow the law, be consistent with everyone who walks through their door.
I think they should stop selling underage children. ID everybody. I'm 64 years old and I get ID.
That's Jennifer Reyes reporting. Authorities say there is only so much they can.
So again, in that instance, our coalitions were really focused on changing practice. The law has existed forever that you don't sell to kids, but the practice was they weren't actually enforcing it, and so they're changing the practice, and they're now beginning to enforce the law, which we're thrilled about. And this is a great final example of coalition work that I'm not sure if you're aware of, but this is a law that was passed this year. Was about you have to have a signature when you get a controlled substance. And one of our coalitions, the Metropolitan Drug Commission in Knoxville, shepherded this. They worked with their legislator, and it went all the way through, which is pretty amazing. And so this is our coalition director, Karen, right there, Pershing. And then those are all the amazing members of her, coalition that worked on that throughout the year. And that was the bill signing. I got to be there, and it was really exciting because they had all worked so hard and come together to do that work. Okay, and then this is just funny. Drop off old medicine, get a free Chick-fil-A sandwich. I was just trying to show you that our coalitions have been very involved and pretty savvy about how they've done that work. So far in calendar year 2014, we've participated in 86 prescription drop-offs. So that day that the DEA sponsors the prescription take-back day, we've had 86 of those with our coalitions. Now, interestingly, if you read what the DEA is saying, they're no longer going to be sponsoring those because now there's other mechanisms. Doesn't mean people can't do them, they're just not going to sponsor them. Okay, and this was about our previous grant, Partnership for Success. Again, it was working on binge drinking, and I wanted to talk to you a little bit about it because it's worked, which I think is what is really exciting about the Partnership for Success grant. We were focusing on the binge drinking rate in the 14 to 24 population. We had 20 community coalitions, and they were working to reduce this in their communities. And so what I've done here in this graph is I actually am showing a 10-year trend. And the reason I did that is we've really been working on alcohol with communities for about 10 years. And so I'm showing you beginning in 2003 to 2013. And blue is Tennessee. And so we've seen a very significant drop in Tennessee in the binge drinking rate. And so we are really pleased and good proof that what we're doing works. All right, so I'm switching off of coalitions and on to selective prevention, which is another part of the Institute of Medicine classification. So selective interventions, and I have Jill here from Frontier, who leads up a Tennessee Prevention Network group here right here. And these groups are focused on specific high-risk populations that we know are at increased risk of using substances. And so I've listed some of them that we focus on here. High school dropouts, foster care children, juvenile offenders, children of substance abusing parents, LGBTQ kids. We know that those kids are at incredibly high risk of using substances. And I've also listed indicated, which is kind of my next area, but that's when you're actually beginning to use, but you're not addicted. So I thought I'd talk for a moment and show you some about some of our TPN services. But we have them all across the state, and they do a lot of different things. So here's an example of one of them. This is called Just Us. It's a program out of in Nashville, and they focus on the LGBTQ population. And so they found that it's really important for them to have an outlet, for them to have a mechanism of talking and to increase parental support. Things like that we know are really important. So that is that group's focus. And then I also showed you another one, and this one's very interesting. This is services for students who are deaf or hard of hearing. Again, a very high-risk group. And so we know that 1 out of 10 hearing people may become dependent on drugs and alcohol, but the statistics for those that are deaf and hard of hearing is 7 out of 10. So they're at very much increased risk, and we've been having, this program has been ongoing for, I don't know, many years. It's a great program that goes in and works with deaf children, works with their families, increases communication, and hopefully decreases isolation, which is a huge risk. Oh, and then this one is another one. We are doing some reach out to juvenile offenders with one of our programs, and so this is an example of that work, because again, we know that's an incredibly high-risk population. And then finally, the indicated prevention interventions. Again, those are people that are experiencing early signs of substance abuse and other related behavior problems, but they could not be diagnosed with a substance use disorder. And then I gave you an indicated example. We don't have as many programs that do indicated services, but the indicated prevention intervention targets high school age youth who attend alternative or traditional high schools, and then the goal is to prevent their transition from drug use to drug abuse. So what I thought I would show you next actually is the work that we have been doing. My boss approached me the other day and said, "Do you want a new title?" And I said, "Maybe." And he said, "How about prevention and early intervention?" And I said, "Yes, I love it," because that's really the work that we've been doing with ESPERT lately for about 4 years now. But if you look at the IOM, it calls it case identification, and that's my best place to put early intervention. It's really there at case identification. I've always kind of thought it should be right here. But our early intervention services are about helping individuals who are beginning to use at risky levels and need to decrease their use. And that's been the focus of our ESPERT work. So ESPERT, in case you're not familiar, stands for Screening, Brief Intervention, Referral for Treatment. And the idea is that you screen individuals in primary care settings has really been the focus for alcohol and drug use disorders. So you screen them right there. You're there anyway to get their flu shot, to have their regular exam. You screen them for alcohol, drug use, and then you teach staff to intervene in a brief way with them, to educate, talk to them about their use. This is unhealthy use. This is why it's unhealthy. This is how it will affect your body. And then help them, motivate them to decrease their use or to seek assistance if they need that. And we use motivational interviewing kind of as the theory behind all of our work with this. But this is an interesting continuum that we talk a lot about with ESPERT. We know that about 70% of people are abstainers and low-risk users, about 25% are moderate to high risk, and only 5% are severe and dependent. But when you go and you talk with a primary care setting, the family health, department, immediately what they think of are those 5%. That's who comes to their mind. And so they're oftentimes scared about taking this on because they think, oh my gosh, this is going to take up all my time and energy, and all we're going to do is, but actually we know that most people are not severe and dependent. Most people, we can talk to them about their use. And this is the area where we have done a lot of focus, is right here. This is where early intervention does its focus, with the moderate to high-risk individuals. We've been helping these people for a long time with prevention efforts, but this is the area where we've really begun to focus efforts with early intervention. Dr. Woodside sitting here, and ETSU has been involved since day one with our ESPERT efforts, and we're at the family medicine program is very involved, and we're at Johnson City, Bristol, and Kingsport family medicine sites, and have been, and they've done amazing work, and so we're really grateful to them for what they've done. And hopefully it will continue in the practice. But anyway, the historic response to substance use is we've done prevention, we've done treatment, and we've largely left out early intervention. We haven't thought about how can we help this individual before they get further on this continuum. How can we make sure that they get the supports they need? So we've let people have catastrophic consequences. And so ESPERT says, no, let's help them before they get there. Let's give them the education, the support they need. It can be less intensive, less costly, but it can be just as effective. And that's what ESPERT has shown. SAMHSA has done plenty of studies on it, and they do show that it is an effective practice. Specifically for alcohol, the research isn't quite as good about drugs, but it is there. So this is just showing. We've concentrated our efforts before on dependent users, but beginning to think about those people that are really making up a lot of the consequences that are associated with alcohol and drug use are the at-risk and binge drinkers. So how do we begin to impact them? Same sort of idea. And then the primary goal of ESPERT is to identify and effectively intervene with those who are at moderate or high risk. Okay, and so again, in looking at this slide, we have those that are abstinence, we go all the way to dependence. We're less worried and ESPERT about abuse and dependence. We've had that system, but it's beginning to think about moderate use and at-risk use and helping people cut it down. Here's the effectiveness information. They're low cost and effective. Brief interventions are feasible and highly effective components of an overall public health approach to reducing alcohol abuse. And SAMHSA has been supporting these programs since 2003, and over 1.5 million people have been screened. This is a reduction in alcohol use that they've seen, a 40% reduction. And this isn't a 6-month study, so they're doing a 6-month follow-up to get this information. So a 40% reduction in harmful use of alcohol and a 55% reduction in negative social consequences, which is excellent. We also know there have been some positive benefits related to illicit drug use. If you guys are familiar with the U.S. Preventative Task Force, they gave ESPERT a B rating, which is the same rating as flu shots and cholesterol screening, so it's very effective. They did not really give it that same rating for drugs. They held their opinion basically on that. And then I thought I would briefly talk about prescription for success. The commissioner unveiled this back in June, and the governor actually was part of that unveiling and shepherded this prescription for success plan, and we've been going around the state and talking about prescription for success. And I have brought some of the executive summaries for you all. But this was an exciting plan because we did combine efforts with all of these different departments that are listed on the bottom of the screen, which was great. Recognizing that no one department can do this work alone, silos don't work, and so beginning to really work together to make these things happen. The report has 3 objectives: to talk about the current problem, to talk about the current ways that we're working towards the problem. Commissioner didn't want people to think that, gosh, we've got a big problem and we know it, but we're not doing anything, because that's not true. We've been working towards addressing this problem for a long time, but we're not there yet, and we recognize that. And so understanding that there are new ways of addressing it, so there are goals. So these are the goals of the plan. The first one is around decreasing the number of Tennesseans that abuse controlled substances, and decreasing the number of Tennesseans who overdose on controlled substances, decreasing the amount of controlled substances dispensed. I'm not going to read all of these to you. There are a variety of strategies in there, including things like passage of a Good Samaritan law in Tennessee is one of the strategies, increasing funding for community work, prevention coalitions, increasing work for low-cost, high-impact work like Lifeline and Oxford House, things like that that have been going on in our state. So theirs are all represented in the plan, and so I will give you the plan so you can see them. But they are represented in here. I think there's 28 or 38 strategies that go along with these goals. So it's an in-depth plan, and you can also, as you'll see on the back of it, there's a link, and you can go to the full plan. This is just the executive summary. It's an 80-page plan. So I was looking at time and noticed we've only got about 10 minutes left. So what I thought I would do is, here's my information. I'd love for you to contact me, but I wanted to see if there were questions that I could answer or we could have any sort of discussion.
So, for the new Strategic Prevention Framework Grant, you talk about some of the common evaluation concepts that you guys are using and sort of how that's going to be evaluated over time?
Yes. It's more tricky because it's the 12 to 25-year-old population. And so we certainly are using still a high school survey. We're still going to be doing surveys in the school level, which is something we've done with previous Partnership for Success grants. But we're going to have to work out a way to get some 18 to 25-year-old level information. And, you know, I don't know that that's fully fleshed out at this point. That's something that we've got to kind of solve before we actually get started.
Sampling is really difficult.
It's really difficult. Yeah, we sat through a presentation recently about some people that had done some work with that age group. People have done it, but it sure is difficult. And so one state had worked a lot with driver's license registries and actually getting information that way. So anyway, we've got our work cut out for us.
Are you thinking like phone surveys or something?
Yeah, although phone is tough because of cell phones, and so we'll have to, there's more work to do.
On the slide you showed a few ago, and then you said you wanted to go through the whole list. Decrease the amount of controlled substance dispensed in Tennessee. So that presumes that the controlled substances are overprescribed.
Right.
What
data do I have to support that?
For example?
Yeah, sure. Well, we know that Tennessee is tied with Nevada as third in the nation for prescribing opioids. And we saw back to this slide a little bit ago about the number of opioids, or the media campaign, the number of opioids that we're prescribing for Tennessee and in our state is way higher than the rest of the country. And so that is the data that we're using.
But does that necessarily mean that we're wrong? Maybe the other countries, the rest of the country is behind us. I mean, I'm being the devil's advocate.
Sure.
I certainly agree. I think it is overprescribed.
Yeah.
But it's hard to get.
So can I speak to this for a second?
Yeah.
The national average is 0.83 scripts per person for opiates per year, and we're at 1.489. So we're 1.49. So what's the delta? 6 something? 0.6 something? That's pretty high.
What was the first number?
0.83.
0.83.
It's a big difference.
We're way ahead of everyone else.
That's a July 4th MMWR.
Maybe everybody with pain lives in Tennessee.
Yes, painful place to live. It's a
There's
ugly
also,
place to live.
I don't know if you've heard about the bill around the Intractable Pain Act as well, but you can kind of look at the Intractable Pain Act in Tennessee, and when that came on, became our law, and the rise in the number of opioids prescribed. And so, beginning to think about other alternatives is not the worst thing. But I know there's a lot of things that go along with that. I know pain scales. I know that there are quality standards that go along with ensuring that patient, that that's right there along with other quality standards. So part of what the plan says we need to do is work with docs around this. It shouldn't be a directive. It should be a collaborative approach. And so I really hope that can happen. And that is the approach that the plan takes.
Yeah, and I think the other compelling piece of evidence is how it's developed over time. I mean, it's been over the last 10 or 15 years, and there's no real obvious reason why the need for opiates in the population is increased.
No, I think that's a great point. Why would our numbers have skyrocketed?
And if you overlay the maps of the highest prescription areas with overdose deaths, they're sort of falling right in line with each other. And then if you look at the correlation between prescribing rates and treatment admissions and overdose deaths, they're all sort of trending right along with each other. If you look at where people are getting the last drug, like the NISDA data, the really, the figure that everybody uses, where you got your last drug that you used illicitly, 60 to 70% are getting it from folks who have a legitimate prescription, and you see one doctor, so it's not the doctor shopping. So you sort of draw a squiggly line between the high prescription rates and the fact that it's sort of an over-prescribing trend.
It's not a perfect line.
I'll ask another evaluation question.
Okay,
The count it, lock it, drop it. Are there specific evaluation metrics for that?
There are. That's one of the greatest things that they've done with Count It, Lock It, Drop It. I cannot speak to those off the top of my head, but that has been one of the things. They're weighing medications. They are counting the number of opioids that are coming in the boxes, and so they've really involved the pharmacy world and an identification of the controlled substances. Yes, they have done some really good outcome work, and if you like, I can try to get you connected with that.
Actually, Terry Love is connected with our working group.
Oh, good.
And he tries to attend the meetings by phone.
Oh, okay, great.
He's even visited with us.
Great. No.
I apologize if you said this, but I was just curious about the sort of end goal for the expert data. For me, it seems, knowing what I know about the instruments themselves, not having seen them, but sort of knowing more about how they're applied, that it sort of constitutes a bit of surveillance with regard to behavior. And we've gone through the same issues trying to get at what the prevalence of use in the population is. Data is really hard to, it's not there, basically. At the county level, and certainly not at the municipal level, but just wondered what you thought the utility of that data might be with regard to you're using in Northeast Tennessee.
So, are you talking about the follow-up study data, or the follow-up part of it?
So the screen itself.
The screen itself.
You ask individuals what their substance use behavior is, right? And then there's a second screen if they're identified as at risk.
Yeah. Interesting. Yeah, I'm trying to think, Dr. Woodside, how exactly we put that information together. We certainly, the part of that information that we absolutely collect is GIPRA information, which is the government's Reporting and Accountability Act. That's not right exactly because I wrote that on the hierarchy. We call it GIPRA data, and it governs exactly what we collect and ask for at the initial baseline and at the 6 month. As I understand it, GIPRA data is available to some extent, even at a standstill level. If we wanted to see more closely what our sites are collecting and keeping, we could absolutely do that, specifically at ETSU. They've been collecting even more data. Often our sites are collecting above and beyond what we have asked them to collect for their own reasons. So ETSU got really interested in whether or not people, the second time they're asked, are more likely to talk about their use than they were the first time they were asked. And so I know they've collected some additional data to look at people over time. Jennifer said no the first time, and the second time she was more willing to talk about it. So yeah, there is some data, but really I can't speak exactly to it.
Yeah, and Cornerstone.
Centerstone, CRI, Centerstone Research Institute, has been our evaluator for that grant. And if you like, I'll happily set us up a call.
The RT part of SBIRT is referral for treatment, and part of the treatment can be medication-assisted treatment.
Sure.
Is there any talk of increasing the capacity? Do we know how many people have accessed medication-assisted treatment of the ones who might want it in Tennessee?
I've never seen any data about that. That's an interesting point. No, not that I'm aware of. I think cost sometimes plays into medication-assisted treatment. And we do know that, well, there's limits on what, and specifically medication we pay for as it comes to I know or methadone, there's limits on who they'll pay for and things like that. So no, I can't answer that really well, but it certainly is a viable option and one that we know.
We probably have a 6-month waiting list.
At your methadone or
No,
Suboxone?
get medication-assisted treatment, buprenorphine, whatever.
Okay. And are you a practice of docs then?
Yes, we're adding our 10th Saturday.
Okay, and how many, each person can prescribe to so many?
Federally, right now, it's 100 after a year at 30, but there's some talk of increasing that because of the need perceived, but we're kind of not really getting, the problem, it almost feels like Ebola in Africa, it's out of the bottle already, and now we're trying to
rein it in. Interesting. Yeah, no, that's a great question. That's a great question. I think, and prescription drugs are they're really different than the other drugs of abuse that we've looked at in the past. And we know a little bit about the people that abuse prescription drugs in our state. Oftentimes they're more educated. Their demographic profile is a little different. And so,
one other comment, I noticed a Controlled Substance Database conference we went to for our state volunteer mutual insurance corporation mandated need to get that education for a year. They lumped buprenorphine in with the full agonist preparations in terms of the daily equivalent dose of morphine. Interesting. And I mean, we've got the cure mixed in with, or part of the cure mixed in with the problem.
That's really interesting. I do not know much about medication. I mean, I know about medication-assisted treatment, but I don't have any facts.
It's a 10-to-1 ratio they give us with buprenorphine to morphine. And if you have somebody on 16 milligrams of morphine, you're 660 morphine equivalent dose a day, and you're deemed.
Yeah.
Or not deemed, but you get a...
Yeah, sure.